Okay, we'll press on to the next session, which is entitled Leading Recovery. And we're delighted that we are joined by Sir James Mackey, who's the National Director of Elective Recovery. I simply lack charisma, don't I? You're just not listening, are you? What do I need to do? I could sing, I don't know. Oh, look, oh, here it goes. There it goes. Ah, lovely. Right, so this session is Leading Recovery, and I'm delighted that we're joined by Sir James Mackey, who's National Director on Elective Recovery. Jim's going to be laying out the strategy on elective recovery that he's developed for NHS England. I think there'll be a lot that'll be fascinating in that. And then we're going to get two responses looking at that through the kind of Northern Irish lens from Maria McElgorm, who's the Chief Nursing Officer at the Department of Health, and Neil Guckian, who's Chief Executive of Western Trust. But first, please welcome Sir James Mackey.
Hi everyone, it's great to be here. I'm going to speak with a Geordie accent throughout, so apologies for that. Probably subtitles will appear at different points. So I'm going to talk largely in my role as National Director for Elective Recovery, but I'm still part-time, so roughly half-time I work in Northumbria Trust and half-time in the national role, and a bit of a sort of regional perspective as well. I'm born and brought up in northeast England, family originally from Ireland, hundreds of years ago. The northeast very like Ireland as well, and very like north, so the demographic mix-up feels very similar. So you'll hopefully see things that you recognise in all of this, but some things will be specifically different just because of the different sort of systems that we work in. So just very briefly, that is Northumbria. We cover roughly 2,500 square miles from the Tyne to the Scottish border, across to the Cumbrian border. As an organisation, we have about 11,000 staff. If you include our commercial incomes, we've got about 800 million turnover. Really massive focus on staff experience and patient experience. So we built our patient experience programme in 2010. Added staff experience in 2018 to really try and get very, very, very focused about that, and that drives all of our key decisions. In the national role, I have to keep reminding myself of those things and bring myself back to them all the time as the politics kicks in and get sort of stuck with performance problems, etc., etc. I was asked to talk about elective recovery, and when I agreed to do this last year for Amanda and colleagues nationally, it did feel a bit weird just talking about elective recovery. So in England, we're doing that largely with a massive focus on it because that's what the spending review gave us money for in the summer of 21. So that at that point, it felt like COVID's over, here's a chunk of money, recover the waiting list, crack on. And we all know life's not been that simple. And I had a couple of months, I started, I think, in October of last year, a couple of months of just trying to get agreement, what recovery meant. Is it size of list? Is it RTT? Is it long wait? Is it patient experience? You know, what do we all mean? Because everybody meant different things. Treasury bought more activity. So what the Treasury wanted us to do from all the models was do broadly 130% of 1920 volumes by the end of the plan, March 25. I think ideally we want to try and reduce waiting times, improve the lived experience of patients, and if we can do that with doing less work, fantastic. We haven't quite managed to pull that off yet. We had a plan ready to go in November of last year as Omicron broke. It was supposed to be published over the weekend when Omicron broke in England. So it got suspended. We then got it published in February, and we've been trying to work through ever since. And I'll show you a little bit of progress on all that. So again, and I'll show you in a minute, it's very different in different parts of England how all this works. And the last phase is very different to the next phase. And just before I'd start jumping into all the graphs and all that, in the last couple of weeks I've spoken to people in the Middle East, in America, in mainland Europe, everywhere in the world, in developed healthcare systems, people are feeling broadly what we're feeling. It's really hard. Workforce is a really big problem. Public attitudes are really changing. Money's getting tighter. Governments are starting to feel the strain of it. It's pretty much the same everywhere. How different systems are built and the constructs and that sort of slightly different. But generally, we are all feeling the same pain. It's important to remember as well that we were struggling before COVID. In any major exertion or event, your recovery is driven by the shape you were in beforehand. And we mustn't forget that. We were going backwards on most of the main metrics in the run-in to COVID. So these are the elective charts and show you what happened before COVID, etc. And similarly in emergency care. So emergency care in England, sure it's the same here, across the world, is an absolute nightmare. And we had, in that first part of COVID, I was explaining to colleagues earlier on, that first part of COVID, I was sort of slightly embarrassed going out of the house at 8 o'clock on the Thursday night and receiving the clap from people in the street, mostly elderly people, 2 retired GPs, because we were empty. We had 50% occupancy roughly through that key period. We were all worried and we didn't know what we're leaning into. We didn't have patients lying all over the corridors and stuff. And then, so that felt a bit odd. And we kind of probably all knew the hard bit was going to come later on. And we're absolutely in a very, very hard bit now in urgent care, largely through a complexity that we're struggling to describe. And I was also one of those people who naively thought, it'll be a bit hard for a few months, and then we'll rebuild and we'll crack on and it'll all be over. And we'll just get on with our lives. I think the bad news is I don't think we're actually at half time yet. I think we're through probably a 5 or a 6 year cycle of complexity. And we just have to keep managing it bit by bit and biting it off into manageable chunks. So as well as those metrics, there were declines in patient and staff experience. The broader health and care system was starting to feel stretched. We were starting to see gaps in social care and big increases in delayed transfers of care. Primary care was starting to struggle. We were talking actively about workforce problems for the first time, having had a few years of trying to work through and get everybody to accept we had a workforce problem. Money was getting tighter, blah, blah, blah. And broadly, we were working a model that was at best built in the 70s and some of it built in the 40s, and trying to expect to withstand a massive shock and deliver public expectations in a very challenging environment. In the last couple of years, just exposed an awful lot of that. And then we mustn't forget, in my last board meeting in Northumbria before lockdown, we considered the Marmot update. Again, in very parts of our population are very deprived. It's a sort of collective sense of shame as to we'd actually gone backwards in a lot of these things, a lot of the key population health metrics, etc., in the previous 10 years. So we had a discussion about, at some point we've got to deal with that. COVID actually helped us embrace that more in the trust, where we created a PPE factory in the first couple of weeks of lockdown because of the panic around gowns, massive community response, business response, university response, volunteering, etc. And we built that into a bunch of commercial businesses that are aimed at finding education opportunities for kids in schools, creating employment opportunities, really challenging whether we need to buy things from other parts of the world. Can we create jobs locally? And remember that if we do that well, 20, 30 years' time, people will be better off, and some of these things will actually start going the right way. So one positive out of COVID and that first impact was it reminded us of our role in society. Another challenge we had when I first sort of turned up and the team were already starting to unpack what does this all look like across the country is it looks very different in different parts of England. Partly because people went into COVID in different shape in terms of performance. The impact of COVID was very, very different in different parts of the country. So parts of England were locked down for very long periods of time. Other parts had short, sharp lockdowns. We're in the Northeast, very allergic to London narrative. So I keep hearing about, London's had its third or its fourth wave or whatever. Colleagues in Manchester say we've had 7. I think we've had 6 or 7, etc. It's just really different everywhere. But when you look at the impact on the waiting list, just purely the impact on the waiting list and long waits, the Midlands and the Northwest have huge problems. So initially on the 2-year problem, those 2 areas covered roughly 40% of our long wait problem. 2 trusts actually covered a massive proportion of our very long wait problem. So we needed a national plan, some national principles, but able to reflect local nuance and differences as people recovered at different rates. Explaining that to a population is really hard. And also, there's a lot of misunderstanding about what the waiting list is and how it's made up. I'll come back to that in a minute. We managed to agree with political colleagues that we'll bite this off over a period of time, bite it off in manageable chunks, really start with long waits, originally 2 years, then 18 months, then a year. We'll just try and work through it methodically. Over time, try to change the system, engage patients more, change the outpatient model, et cetera, et cetera. And the good news is we've managed to make a lot of progress on the first bit. So some key themes in the plan, and if you had a chance to read the plan, those of you that have been involved in national processes, when you set off these things, I had really naive ideas that I'd actually recognise a lot of it at the end. Often you don't recognise much of what you wanted by the time it's actually published. And you do, you lose a lot in the political discussion and the attrition of agreeing with people, different things, etc. So the key principles from my point of view, and many of these are there, they're maybe not emphasised in the way I would have liked them to be, but key thing, for the first time ever, try and separate urgent and elective care and build resilience into both streams. In my Northumbria life, we've been structurally separated in urgent and elective care since 2015. So all of the hot emergency work happens in one site, including emergency diagnostics. All of elective care happens on other sites. So you never have a situation where a surgeon or a diagnostician is having to juggle, I want to do this planned thing now because this person's been waiting a long time, but I've got 3 emergencies just come in the front door. Try and build resilience in the system. And huge investment across the country to make some of that happen. Recognition that we're being under-resourced from a diagnostics perspective and some of the investments being targeted at that, and that's, there's an ongoing process there. I really wanted to invert the outpatient model as part of all this, and I'll show you some of the maths later on this, but basically move away from this. This is driven by personal and family experience. Move away from a model that says clinician sees you, puts you on a treatment path, books you in every 6 months for the rest of your life, whether you need to see them or not, or says, you're all right, started your treatment, tell us when you want to see us again. And this is what you do if you need to see us. And there's huge resource tied up in that follow-up system that I think increasingly find it hard to justify to a population when we're not on top of our workload. And I'll talk about that again in a minute. Part of that, activate patients, give them more control through technology eventually, so the public in England trust the app because of the COVID vaccine and those sorts of things. Make the NHS app a portal into the NHS and enable patients to book their outpatients, tests, change appointments, have an interaction with the clinical team, etc., etc. There are portals in use now, and over time that'll get embedded properly into the app as a gateway into the NHS, and Choice can help facilitate that as well. Focus on long waits. Continue to try and deal with productivity and variation, and we've been challenged a lot in recent weeks from political colleagues on the extent of variation. Why is one organisation 7 miles from another still only doing 90% of its 1920 volumes? The one next door is doing 104% of 1920 volumes. Why? Why has one got 85% theatre utilisation? The one next door's got 60%. Why? Why is one saying they can't do inpatient operating. They've got the same occupancy as the place next door. Usually we can't explain that. So that whole variation thing is a really big issue for us all to get around. And the productivity and the flexibility thing's a really big issue. So at the beginning of COVID, we had massive flexibility driven by extremists. And we all celebrated specialist surgeons working as generalists at the front door, mucking in, people who weren't trained in intensive care, mucking in, working together. We all said we wouldn't go back to normal, and we've all gone back to normal with knobs on. We're more rigid, more siloed, more protected now than we were pre-COVID, and it's a really big enemy for us as well. And then we've got the spectre of the requirements of the spending review in the background. And in England, in all of our models to support the spending review and the plan, there were 11 million patients missing from pathways in our system. So if COVID hadn't have happened, there would have been 11 million more people in elective pathways than we could see when we developed the plan of 60-odd million people who live in the country. So that was a huge risk. It blew every other number in the plan. Almost every other number in the model was irrelevant, because if 11 million people turned up, we were finished. So it was always my instinct that a lot of those people would be in urgent care, they'd be being managed at home, community and primary care, they'd be in mental health pathways, they'd be in cancer pathways. And we have seen a big increase in our cancer bounce back as well. And some of them have died. And we're still trying to work through now whether we've still got much of it to see or whether they're actually all in the system. And as part of that, we'll have to go searching for people in different parts of society who, for some reason, are now unable to access the service. So I think we've probably seen a lot of it, most of it, but we're not going to know for a while yet. So we need to not get too distracted from it. But 11 million people. We actually had the benefit of huge investment, as I said earlier on, to start supporting the separation of urgent and elective care, development of surgical hubs, et cetera, and a lot of diagnostic investment as well. Just quickly, I'll canter through the next bit a little bit quicker, just to try and get the messages across on this. There's roughly 7 million people on our waiting list in England. And we all think, the media think, colleagues think that they're all waiting for surgery. 80% of that 7 million will end their episode in outpatients or diagnostics. 80%. Only 3% has an inpatient surgical stay. So we'll have to understand the numbers and the maths and all this if we're actually going to make an impact on it. We had an exchange overnight. I don't know whether this is true or not yet. We're still trying to get underneath it. But of the 7 million, we think there's only just over 5 million people. So you've got people who are on the list more than once. Some of that's legitimate, some of it's not. So there'll be double counts and all of that. It's pretty powerful if you can actually understand that properly. It's very differential around the country, as I said earlier on. So we need to recognise all of this. And the first bit, the 2-year wait problem, was largely surgical. The 78-week bit that we're in now is largely outpatients. So, and we're moving that really quite dramatically now. So there's been throughout a really strong focus on outpatients and trying to shift the model. Some of our most challenged trusts on 78 weeks can deliver comfortably what their 78-week challenge is if they adjust reviews by 2 to 3%. Not 50%, which looks possible in the model. 2 or 3% can go from it looking impossible to looking comfortable in terms of delivery. And we're really just trying to get into all of that now. We're broadly at the point we wanted to be, or hoping to be, in October on the 18-month challenge, the 78-week challenge. We needed to be 45,000 or something, sort of number to go into the next half of the year and be able to deliver 1-2 at the end of financial year. We're just about there. To work out how we supported organisations and held them to account, we split them into 4 segments, so a tiering approach, which we've used in the regulatory system in different ways over the years. So the idea would be in Tier 1, you're under national scrutiny and support. Tier 4, you're fine, just, crack on, no one's going to bother you, just keep going, etc. And all of the organisations that have been in Tier 1 and Tier 2 have done a fantastic job. So the rate of progress across the country has been absolutely incredible. You'd never believe it if you read our papers, or you looked at the media, you'd think, we're an absolute mess. But on 2-year waits, this time last year, we were heading towards having 40,000 people waiting 2 years at the end of March. We got through a terrible winter, resurgent COVID, massive COVID occupancy, loads of sickness absence through different waves, especially in the spring. As of today, we've got about 2,000 people waiting. Of that, who've waited 2 years. About half of them have refused options to have their treatment somewhere else or in a different way. So there's about 1,000 who the NHS, you could argue, should have been able to treat and hasn't managed to yet. We're trying to get that to nil as quickly as we can. And the way people have gone about it's been absolutely fantastic as well. So a lot of it's been sort of traditional performance management, getting a hold of the data, all those sorts of things. But the way people have embraced technology, e-forms, chatbots, the chatbot stuff's had a fantastic impact in Lancashire, very challenged system, basic SMS, communication to patients. When people have been on the list for a long time, there's a couple of certainties. One is we probably haven't spoken to them for a long time. Probably their lives have changed. They might be less interested in having what they're originally listed for. And usually the data's crap. So when you start getting to it, you'll find very quickly the data is actually useless, and you can make a massive impact just by validation and getting the clinicians to work through what's on the list and whether they are still people who need to be treated. Almost nobody this time last year, no clinician, understood what was on their list. Almost no practice in primary care understood what was on the list from their perspective with different providers. So we're just working through all that now, just trying to share the data, get people to validate and work through what impact could be made there. We've had Super September, which was aimed at just trying to stimulate innovation and sharing ideas, loads of fantastic effort with pretty much every organisation in the country. My organisation sort of grudgingly accepted it. There was a lot of grumpiness. Do we really have to do this? These crackers, if we just ignore them long enough, we don't have to do it, et cetera, et cetera. But when you get into it, there's lots of things sort of come out. Maybe we should every few weeks just have a focus on news. Maybe we can do something about reviews. Maybe we'll try virtual group consultations, all those sorts of things. Different ways of trying to get back on top of the workload and give patients what they need. For a long period, one of our most valuable, if not the most valuable clinical activity has been clinical validation. It sounds really hard to explain, but often a clinician is better spending a session tidying up the waiting list, talking to patients, working out whether they still need what they were originally intended to have versus actually seeing patients, because the lists are so, they've become so out of date, etc., and especially with long waits. So an awful lot of effort going into clinical validation around the country. There's a couple of slides in here that I've been using in different things in recent weeks, but one of the really strong things in all this, and you can really feel the pressure trying to make us all do when we're all under pressure in urgent care, got no headspace, etc., is to just rebuild what we used to have. What we used to have wasn't working, and it didn't withstand the shock fully. Let's remember we've got a lot of benefit out of the innovation and flexibility, etc., through the first waves. Let's try and reassemble new bricks, not the old ones. We've absolutely got to try and facilitate clinician-patient dialogue on all this. This isn't just a management system fiddling about with numbers and lists and stuff. We've got to enable people to have proper conversations about what they need. If you were listed for a gallbladder up 3 years ago and COVID allowed you to lose a lot of weight, you probably don't need it now. So let's have a conversation about whether you actually need that, whether it's right for you, et cetera, what else is going on in your life. Be driven by the data and facts. And I do, if you access HSJ, I'm getting slaughtered in HSJ today about all this, but it's really frustrating how few people actually understand the data and understand their data. I've had arguments with people about whether they can do what they need to do because they've got no beds, because they're full from an urgent care perspective. But the long wait problem is all dermatology. they're not going to go into medical beds. Really understanding what is actually driving their problem. The problem's all outpatients, et cetera, and really try and get people to take ownership of that. There's a load of appetite going on. There is a lot of innovation going on around, and let's learn from each other and really understand how the lists is made up, et cetera, as well. So these are some challenges we're putting out in the system now. Organisations in Tier 1 and Tier 2 will have to do a board self-certification in the next few weeks to confirm they're doing all the basics. The board's seeing the data, they've got a plan, they've actually considered how they're going to get through winter rather than just assume they're going to get through winter, et cetera. So a lot of sensible stuff. And we are now under much, much, much more challenge on value for money, given the state of the economy. And you can feel that pressure now from other parts of the public service and the economy generally. So just before we wrap up, there's a load of challenges in all this, and you can really convince yourself it's not possible. The NHS has done a fantastic job. You've done a fantastic job through your version of this in the last few years. The NHS as well has done an incredible job on the long wait challenge whilst we've been going through all this additional complexity and navigating just the last few months even. And now we're looking into a tough winter. We should do that with confidence in the way that everybody's managed to deal with it so far. There's a load of innovation going on about. We've got virtual access to outpatients now that we didn't have pre-COVID. So theoretically, we can level the load. We can give people who are going to wait a long time in Devon access to a physician in Newcastle. Now, completely practically, that's totally possible. Theoretically, you can do it across the world now. So embrace some of these things, but let's be driven by the data. Let's not forget the public who are really stressed about what's going on and access, etc. Try and look whole system as much as we can, primary, secondary care, community services, etc. And let's not let the defeatism and negativity get to us. And remember, patients and staff throughout all this. It's really easy to get driven by the numbers and the performance management and all those sorts of things that we naturally get driven to. And then finally, this isn't just something we're experiencing. It's the same across the world. There's a lot of learning across the world. A lot of people can learn from you and the things that you've done. And I'm pretty sure we'll get through this next phase as well. So just some final thoughts there on disruption and getting people to take local control. Handing back the keys is a local thing with My Trust, about trying to enable people to take control again of their teams, their departments. We're in a level 4 incident for a long time, and that really disables people. Let's not forget urgent care and primary care and social care and mental health services as well through all this. One of the big things that's thrown back at me all the time, and I have this problem myself, and I've got it with the local management team, is headspace. No one's going to give us headspace. We have to carve it out ourselves somehow. That's the bit that's going to get us free from all of this. Just expecting everybody to work harder isn't the way out of it. But I think we've got enough innovation, will, agility, flexibility, and performance over the last few years to be able to deliver what we need to for patients and staff. So I'll stop there. Matthew, happy to have a discussion.
Thanks, Jim. That was really inspiring. Maria, it's up to you. Yeah, great.
Thank you, Jim. That was very inspiring, and I think one of the important things for me from coming to Northern Ireland, I have a 92-year-old mother, is the number of appointments that she's been actually sent out since I've arrived here. She's probably had about 10. She's 92 and probably doesn't need any of them, and probably in the last 1,000 days of her life. So I think we really do need to learn from this. It's really, really important, and particularly for our older people. So just a bit for me, new CNO for Northern Ireland, 8 months in post, first NICON conference, so thank you very much for inviting me. My job in the Department of Health is really the professional policy lead for nursing, midwifery and AHPs. And I do believe that our professional groups are a part of the golden thread for actually recovery, working with our pharmacists, our medics, and the wider social care family. So that's really important for me that we do this, and we do it on a whole system place. I actually did my presentation around my view from Stormont, because Northern Ireland is very new to me, having come from Scotland. I started in the Republic of Ireland, moved to England, then moved to Scotland, where I've spent the largest proportion of my career, and I'm now back in Northern Ireland, so I'm very privileged to be here. One of the things that struck me about Northern Ireland when I came was the population size of 1.9 million, and when I put that into context, that's probably not much bigger than Greater Glasgow and Clyde, or indeed Greater Manchester. But what I have noticed since coming to Northern Ireland, there's a lot of hospital-based infrastructure. The challenges that we face in Northern Ireland are those faced elsewhere in the UK and globally, and in a way that's probably quite reassuring. We've just emerged from the pandemic, and that has had significant impact, I know, in our communities, our staff and our services. We've seen an increased demand, and actually I spent 12 hours in A&E recently with my mother, and it was really, really interesting to see how busy and what a demand is in our services. Particularly, we've seen demands in mental health, children's services, elective, A&E, primary care, it just goes on. Importantly, I think, similarly to the rest of the world, we have an increasing older population, which is in itself something that I know we should be celebrating, but there's a global recognition that this is placing increasing demands on our health and social care services. And many of the people who care for older people like me also are part of the working population. We have a widening health inequalities, which has been compounded by the pandemic and will be further impacted by our economic crisis. In Northern Ireland and across the globe, we are reporting rises in complexity, comorbidity, frailty, and a significant proportion within our older population. When I was in A&E recently, the biggest number of people in A&E were actually older people, and I did ask myself, should they all actually be there? Securing and retaining a responsive workforce to deliver safe and effective care is also a significant challenge that we're facing. And when I add in the political instability, proposed reductions in public spending, the legacy of the trauma, which is quite unique to Northern Ireland, to the Troubles, it gives us a lot of wicked issues that we need to handle and solve. And I know we can't do this individually or by one service, but I do believe we can do it collectively. My slides aren't going on, but it doesn't matter, I'll just talk to it. I do believe, though, having come from Scotland and with previous experience, that Northern Ireland has all the ingredients for success. And the reason I think this is because, one, you have a fully integrated health and social care system. And having worked in Scotland where they tried to integrate health and social care and now they've moved to a new model, there was lots of difficulties with that. And the main one was that there wasn't one joint budget, which you do have in Northern Ireland. We've also got implementing Encompass, which I think will be really exciting. And I know that my colleagues who've had demonstrations in Scotland are very envious of that. And I'm sure that that will help us as we move forward. Since coming here, I've been profoundly struck with the collective willingness of all our staff working in health and social care, in the Department of Health, the independent and the voluntary sectors, in wanting to do the right thing, working together to improve outcomes for people in Northern Ireland. And I know this echoes the Minister's thoughts this morning. It is long recognised that our workforce is by far our strongest asset, and this was evidenced in our responses to the pandemic. I believe that we have to harness that innovation, and Jim has touched on that. And we must learn from the pandemic and not move back to where we were before, because we weren't doing things right. However, I also recognise that the pandemic has had a significant impact on our frontline staff, resulting in exhaustion, demoralisation, and some contemplating leaving our careers. Whilst it is crucial to address those concerns, I'm also acutely aware that coming from Northern Ireland, there's been a lot of investment over the last couple of years, both in workforce and in new service model designs. I know also that we have to actually ensure that going forward, our investments in health and social care are really targeted wisely. And I know the Minister talked about off-contract agency. I can say to you today in this audience that Northern Ireland has got the biggest spend per population across all of the 4 countries on off-contract agency spend. So how do we drive recovery? First, I think we need to get through what I think might be one of our most challenging winters. We have an individual and collective responsibility to protect ourselves, our families, our patients, our communities, and our health care services. So I'm just making a ploy, because every contact counts, for everybody to get their vaccines to help with that. I think it would be really important. We need to recognise that getting it right for older people must be a key priority within our recovery plans. We need to develop clear whole system pathways, and this requires a collective and collaborative response involving all those who use and provide our services. Our workforce is key to delivering a high-quality health and social care experience. It is widely acknowledged that our workforce cannot deliver an excellent experience without having a positive working experience themselves. We need to offer solid support to our staff, making the health and social care service in Northern Ireland a great place to work. We recognise that there are many wicked issues we need to address to lead recovery. To address these, as leaders, we need to create the conditions to allow creativity and empower our frontline staff and service leaders to lead recovery. Of course, we must rightly focus on responding to ill health, but our future goal must be to move to a model of prevention and early intervention for prevention. We must make every contact count. This will require both a cultural and paradigm shift in all our thinking, the ways we work across health and social care. And we must recognise that hospitals should only be for acute episodes of care and for the shortest period of time. This is vitally important for our older and frailer people. We know that the transformation of primary care, and when I use the term primary care, I include community health and social care, is a key ministerial and World Health Organization priority. So this has to be a focus of our recovery. Changes and improvements are being made across the UK. As we plan to rebuild and recover, some of this may require long-term planning and investment. However, we must learn from others and share and scale practice. And I think we're really, really good at innovation. What we're not good at is actually scaling it. Finally, in an increasingly digital world, we need to ensure that recovery is data-driven, evidence-informed, and outcome-focused. Key to this will be improving data linkages across our systems. So finally, I believe, here's 8 months, and I hope you all believe, that our health and social care can deliver the seemingly impossible. We have the people, we have the skills, so we need to demonstrate collective leadership, working together to achieve. Like Jim has said, together we can harness the innovation and the learning from what we did in the pandemic. I think that here today, we have a room full of such folks, and I look forward to working with you to fight the fight to achieve a world-class service in Northern Ireland. Thank you.
Hello, folks. I've been asked to give a Northern Ireland Trust perspective, and thank you, Jim. Your troubles are our troubles. We have the same issues in terms of rebuild, so I'm not going to, you'll be delighted to hear in terms of the timescales, I'm not going to repeat Jim's presentation. Those who know me will not be surprised if I start with the financial challenge, the financial turbulence, I would call it, and I was very taken by quite a few of the comments already today. Firstly, we've heard that funding cutbacks are coming, and it's almost this drip, drip feed of fear that we have of what's imminent. But we have to set that behind us, and I'll come back to that. There is the potential, we keep hearing, of losing any overspend next year. So that's, again, more doom. been very taken by Gráinne's comment, but we're not just an acute trust. We're health and social care. We have to be so mindful of the financial stress in our population, and it manifests in so many ways. But we need to get back to focus. We spend billions of pounds. So this is an opportunity for us to look at what we do, how we do it, and how we spend our money. This will be, however, the first winter, probably in my career, where there isn't extra resources being presented for a winter plan. So we need to start getting innovative. In terms then of going back, I make no apology of talking about workforce, and I know Maria and Jim have talked about that. We are losing staff for a variety of reasons, and we cannot be judgmental on those reasons. We all make career decisions. It's because of workload and stress. It's because of post-COVID changes in life choices, and so many of us have made those sorts of decisions. The cost of living crisis has made people decide to change their employment. Work-life balance, rota flexibility, which is close to my heart, and also the opportunity or lack of risk in terms of agency working, as Maria has hinted at. But without a workforce, we have no service. If you can't talk about elective, as Jim has said, without thinking about unscheduled care, beds and flow, unscheduled care versus elective access, they almost are competing at the moment. Our hospitals are really struggling to maintain flow due to discharge delays, linked, in my view, to workforce issues in domiciliary care and other factors in care homes. So our winter will be tougher than ever before, but we will have to stand together and we will get through it. So how will we address it all? Well, today and tomorrow we will continuing to hear so many examples of improvements and good practice. We must scale and spread them. By working together as a system, we will get through this winter. By driving improvement, we'll get through this winter. By learning from each other, we'll get through this winter. But also being flexible with our staff. And I was at one of the events at lunchtime. Milton Keynes is allowing all their staff to choose their hours, and they're building their service around that. Something we can look at, because certainly our staff are telling us things need to change. Productivity has been discussed this morning at quite some length. Talking to the right person there, definitely. But basically, what can we do in terms of what's within our own gift? Theatre utilisation, Jim referred to. In the Western Trust, we did an awful lot of work on this before COVID, and we made great progress, albeit from a very low base, but we made fantastic progress in this. But we've lost the gains during COVID. We've lost staff again. It's a vicious circle. We need to we are rebuilding that work. We will get that back, and we already started that journey. We need to separate emergency from elective, and that is an extremely, at times, difficult conversation to have, and I'll come back to the conversations. And it's no coincidence for my organisation that we are over-delivering, against baselines for day case work, because we have the OMA hospital, which does not have a link to unscheduled care. By separating out elective, we're able to focus on our day case work. That is something we must do. We must focus on our day case work if our beds are so pressured. And we need to bank these improvements during COVID and improve further. So rebuild isn't just about acute hospitals. Daycare is an issue very close to our population. Domiciliary care also. AHPs, we will all need sustained improvement to make our systems improve. I'm very conscious, we've been talking about society, and Jim's talked about social deprivation. Well, you've come to the capital of social deprivation, Jim, Northern Ireland. Not only have we historically had the most social deprivation, but the Office of National Statistics this week have announced, in terms of the movement in the nations, Northern Ireland have a greater reduction than any other area in the region in the UK in terms of reduction in income for households. We're already the lowest, and we've fallen by more than everywhere else. So remember, with levels of social deprivation already worse, the current cost of living crisis will inevitably increase demand for a range of our services, including mental health, as just discussed, family and childcare, and across our hospital services. We have a lot of strategies and a lot of change, but our core service needs focus and support. A few issues. If I get a soapbox, I'm very predictable about a couple of issues, folks, and I'm not going to apologise. Equity of workforce. I come from the Wild West, folks. I lived in Derry all my life. We need senior and junior medical workforce equitably spread across Northern Ireland. Otherwise, system capacity won't be sustained. This shouldn't be a threat to anyone and any organisation in Northern Ireland, as it will make our full system work better. Rural communities, subject very close to my heart in recent days. They need respect. How do we bring them with us? We need to change, but we also need to convince all of society that the outcomes will improve. My feedback from my local community is, why should rural communities always be the perceived losers? So to finish, I'm going to finish with some positives, folks. As I wander around my organisation, sometimes that's what it feels like. Every day, I see innovations. And yesterday, for example, Peter came up to visit the West, and he came into CETRIC, our research organisation. I was absolutely flabbergasted by the innovation going on in just 2 rooms we happened to wander into. David Gibson's here from University of Ulster. He was presenting on the research into the impact of COVID and the analysis of COVID patients who had mild symptoms, severe symptoms, and then 6 months after, and trying to get behind the whole concept of long COVID. It was absolutely fascinating to listen to all the clinicians around the room, their analysis of that scenario. And then we wandered down the corridor, and John McGoran, one of our consultants, came out and described linking innovation to our problems. We have massive waiting lists for endoscopic services. So they were testing across the UK. He was one of the test sites to test a mechanism whereby you swallow almost like a vitamin pill. It dissolves, and then it turns into a sponge or a Brillo pad. They take it out of you, and you don't need any real major intervention. So they can then use that as a biopsy. Fantastic innovation. By doing that, that can be nurse-led and not doctor-led, and we can blitz the waiting list into the future. So my other plea, a couple of final pleas. Let's go for 2 or 3 priorities. There's an awful lot of moving parts at the moment in health and social care. And where there's moving parts, then you don't hit the target. Won't go into targets. We're working as a system with more regional waiting lists and work. Let's really focus also on community services. Measure them, measure the impact, and prioritise the impact. Let's use the digital gains made during COVID. I never thought I'd say this, but as a provider of GP services, which doesn't quite come out of my lips naturally, 60% of the patients of Drumore practice are quite happy to take a telephone contact. So 40% need to visit face-to-face. So going back to the conversation earlier from our Royal College of GPs, that's absolutely right. We have the evidence to support that. Let's bring that into hospitals more. And I suppose two final statements. Let's make it a doable ask for all our staff. And finally, we have dark winter ahead. It's important that we all pull together during that period. Thank you.
Thank you, Neil. So we have a very distinguished guest to wrap up the day, and I don't want to leave him waiting much longer. And so therefore, I'm just going to completely take advantage of the fact that I'm the chair and only ask one question, which I'm going to direct to Jim, if that's okay. And Jim, I know you have an answer to this question, but I'm really interested in the nature of that answer. So there's a lot of talk, and there's been a lot of talk here as well, about the need for us to think about fundamental shifts in the health service in relation to more system working, in relation to prevention, in relation to health inequalities, population health. And we've been talking in the health service for decades about the need for this kind of shift. And yet, the precision and the positivity that you give to an account of change, which is a much more traditional model of change in many ways. It's acute-led, it's quite centralized, it's target-driven, and yet of all the kind of contributions we've heard over the last day, yours is in a way the most positive. And I suppose the question I've got to ask you is, and I say this as someone who worked for Tony Blair in the years of Michael Barber and that kind of target-driven approach, which had big outcomes, and again, the investment generated the results, but in a way that stuck with that traditional acute-dominated health model. So I guess my question to you, and I know it's a long question, is how do we combine the kind of brilliant work that you've described, which could in some way seem to reinforce an acute, central, target-driven model with the kind of aspirations for more system working, more preventative work, and that kind of leftward shift? Sorry, it's such a long question, but I'm deeply fascinated by your answer.
I'll give you a long answer then. So I think first of all, we shouldn't fall into the trap of seeing them as binary and either-ors. So in my trust life, they're not either-ors. We're putting as much effort into community services, our ESG and CSR work, the support in communities, all those things are, and we've got a public health infrastructure within the trust for which we receive no income. We decided to do that ourselves. All of those things are getting effort. So first of all, they aren't either or. They have to both happen. We'll fall into the trap of them feeling very either or all the time. We've got to avoid it. The second point is we'll have to probably, I think, and colleagues have said this as well, bring some of the precision of measurement and improvement science to community services, mental health, social care, longer-term determinants, etc., things that work, because the science works in everything. And often what we struggle with in community services is the absence of data, the absence of impact. And so, very live issue across the world is the people who are in hospital beds for want of a domiciliary care package. My instinct is, and we're trying to prove this now, that if you got roughly £3.5 million tied up in running a ward, about £1 million worth of domiciliary care gets those people home. So let's start measuring those sorts of things and looking at the impact and making good decisions about it all. And then the final thing, I'm an accountant as well, so I'm sort of got numbers in my heart. The financial impact of investing in community services, primary care, longer-term determinant, and certainly public health is absolutely tiny in the scheme of things. So in a hospital, you get nothing for 3 or 4 million quid. You can get a hell of a lot for 3 or 4 million quid in terms of primary care. Certainly community support in vulnerable communities. We probably couldn't spend that in my population. So let's help some of that drive our discussions about decisions and investment decisions and take responsibility ourselves. We've got a terrible addiction in our system to look for permission, wait for instruction, all those sorts of things. I'm completely built to reject that. Let's all grab a hold of this and work out what our version of that is. And frankly, if in our local systems, if we spend 0.5% in some of those longer-term determinants or whatever, frankly, we probably wouldn't notice it, probably have a huge impact, but we'd need to prove it, we'd need to measure it, we need to have confidence that we can show it's worth it.
Yeah, thanks, Jim. And I think that critical to that is how can we talk about prevention with faster feedback loops. Often we talk about prevention as if it's a kind of heroic intergenerational challenge, but actually stopping people having medical interventions they don't need, secondary prevention to stop people who've got one condition getting a second, a third or fourth. There are fast feedback loop possibilities for preventative work, but we need the data and we need to demonstrate that. And then once you've got those feedback loops working, you can start to move to bigger and more ambitious objectives.
Absolutely. And I think we're also in a position where, and this is really counterintuitive, because we've spent our lives trying to manage demand, restrict demand. Given what's going on and what's happened to the most vulnerable in society, we probably need to be trying to find people and catch them before it's too late. And that really feels odd, because it feels more expensive. It's probably not. But, let's not just wait for them to hit the system later on. And I think you're absolutely right. I think a lot of this stuff will actually see more immediate and short-term impact than we think we'll have. We'll definitely not if we don't try. And on your points on the vulnerable elderly, etc., it's just, we've got a model that's putting people in the wrong place, treating them inhumanely, not like people, probably exacerbating the shortening of their lives. And we've got to stop that. Only us can stop that. Government won't stop it. We have to take responsibility for that.
Well, I think that's a great message on which to end this session and the day, apart from what was going to be a fantastic final session. I'll hand over to Heather for that. But please, can you join me in thanking Jim, Mackie, Maria and Neil.